สวัสดีค่ะยินดีต้อนรับทุกท่านเข้าสู่ iAOC Course Series นะคะ Good morning audience from Thailand and good evening Dr. Ho from Indiana.
Good evening.
Good
morning for Thailand people.
Yes, good morning for Thailand people and good evening Dr. Ho. So welcome everyone to iAOC Course Series Special Edition Advanced Imaging during COVID-19. Today is Module 5 with the in the pediatric neuroradiology with the collaboration with Indiana University School of Medicine and Riley Children's Hospital. And this is last week for this module, and we are going to talk about update in pediatric brain tumor. How precise can we tell based on imaging? Can we tell about the radiogenomic, or can we tell about the genetic mutation on brain tumor in children based on imaging only? And this is my great pleasure to introduce Dr. Chang Ho, who is my teacher, my mentor, my friends, and of course, my boss from Indiana University. He keep pushing me to be a good radiologist and a good teacher. And he keep pushing me to put the name of the gene mutation on the brain tumor that I read every day at Riley Children's Hospital. Please welcome Dr. Ho. Hello.
Thank you. I'll go ahead and start by sharing screen, start my lecture here. All right. So it's my pleasure to have this opportunity to give this talk. This is actually a very favorite topic of mine, which is kind of like the radiogenomics of pediatric brain tumors. And kind of like Tanya said, it's basically how much can we tell what is the molecular classification or the genomics based on imaging, right? Because that's we're radiologists. We want to be able to predict not just what kind of tumor it is based on pathology, but also what mutations or epigenetic things that it may have, which actually has a very important clinical function, which we'll see. So our objective again is to give you an update on recent molecular classifications of the more common pediatric brain tumors. And also, again, like we said, not just imaging findings to suggest what the histologic diagnosis is, but also a subclassification. So combining radiology images, radio and genomics, like how can we predict these things based on our imaging? And so we'll go over Medulloblastoma, EPendymoma, atypical teratoid rhabdoid tumor, or ATRT for short. And then we'll finish with looking at gliomas, both low-grade with the most common pilocytic astrocytoma, as well as the high-grade glioma, a new kind of classification called the diffuse midline glioma. I think it's important to go ahead and start with a few definitions. So a very broad molecular biology essentially is the molecular basis of biological activity between and in cells. So essentially what we're describing here is the kind of basic process of DNA making RNA, which then translates to proteins. And then genomics is also a very broad term, but is more centered on the DNA. So we're looking at the structure, the function, and evolution and mapping of genomes. So when I throw out words like molecular classification or genomics, this is actually a somewhat broad term. More specific terms that we'll talk about are like signaling pathways, And so these are a group of molecules that work together in a cell to control specific cell functions. So two of the pathways that we'll touch on are the WNT, or the wingless pathway, as well as the SHH, or sonic hedgehog. And so these are actually discovered in fruit flies, so Drosophila fruit flies. So you can imagine a mutation in the WNT pathway will typically give you a wingless a fruit fly. And then sonic hedgehog actually has a very interesting background for why it's named that way. So apparently the discoverer back in the 90s, when he saw this molecule, he thought it looked like a hedgehog. However, there are other proteins that were already called like Indian and desert hedgehog. And so his kids were playing, this video game quite often. So he decided to call it sonic hedgehog. And so here you can see the protein molecule actually kind of does look like the video game character. And so this name kind of stuck. And then we'll also talk about epigenetics. And so these are modifications of gene expression without altering the DNA. So there's not actually a mutation of the actual DNA, but how it's kind of modified so that it gets translated or not. And so the two main ways of doing this are through methylation, so adding a CH3 group onto the DNA strand itself, or on these molecules called histones, which are essentially these rounded proteins. And here you can see the DNA double helix kind of wrapping around the histones. And so you can see like when it's wrapped around, it's harder to translate, but when it's free from the histone molecule, you can translate it and make proteins better. So depending on how it's associated with histones, you might get more translation for this DNA or less. And then finally, the actual gene itself that regulates cell growth or proliferation or apoptosis is called a proto-oncogene when it's not mutated. But once it's mutated, you can call it an oncogene, right? So oncogenesis, which drives tumor formation. And so these are all different ways of, through molecular biology, all these different ways that you can modify or cause different gene functions through these different pathways. And so our tumor subclassifications all can have these different effects too as well. All right, so why does tumor genomics matter, right? So we kind of talked a little bit about this. It really has the clinical differences between the different tumors. So here we can see a T2 weighted image of this kind of like midline tumor, and we see that on post-contrast images, it has this heterogeneous enhancement. And on the apparent diffusion coefficient, clearly it's a little darker than the cerebellum. So already we know if this is a child, this is a very classic, posterior fossa, fourth ventricular midline tumor, we should be thinking about, in high grade, we should be thinking about medulloblastoma. So let's compare this to another tumor, which looks very similar. Here again on the T2, we can see that, again, it's located midline in the ventricle, has maybe a little bit of cysts and stuff. This one has a little bit more edema, but otherwise looks very similar. Again, enhancement, kind of heterogeneous, but very similar. And of course, the ADC is dark, again, showing that it's hypercellular, and so a high-grade tumor. Again, we should be thinking about medulloblastoma in a child. On pathology, we can see that they actually have the same histopathology, and sure enough, it is a classic pathology for medulloblastoma with these small round blue cells. There's other histopathology which you can see in medulloblastoma, but this one is classic and for both of them. However, as we'll see, when we kind of look deeper into either the genomics or molecular differences between these, we find that the top one is actually a group 3 or probably group 4. This one's probably group 3 because it enhances, and we'll get to that later. But the bottom one actually is a WNT tumor. And so this was a wingless pathway tumor. And the big reason why this matters is because they have very different 5-year survival. So here in the WNT, you can see that they have an excellent survival of 5 years at greater than 95%. And for group 3 or group 4, it actually has a range of 22 to 72%. So anywhere from intermediate to poor. And so this WNT medulloblastoma acts like a benign tumor, right? So it's a high-grade tumor, but actually acts like a benign tumor. And so the genomics really matters because their outcome is so different. So getting into medulloblastoma subgroups, there's 4 kind of large recognized subgroups. So WNT, SHH, group 3, and group 4. And here's the frequency of medulloblastoma. So basically, WNT is the most rare. It's about 10% of all medulloblastomas, whereas group 4 is the most common at 40%. SHH and group 3 are kind of in the middle. And if you look at ages, age is actually very important. Here we can see the WNT subgroup is primarily teenagers and even young adults. The parentheses show the male to female breakdown, so it's pretty even in WNT. For SHH, we can see that there's infants, but there's also kind of older kids too, and rarely adults. Group 3 tends to be a little younger, so more infants and younger children. And group 4, not so many infants, but kind of like children to even adults. And so adults obviously are pretty rare for medulloblastoma, but if there is an adult medulloblastoma, most likely it may be in group 4 or potentially SHH. Group 3 and group 4 also, you can see that has a more of a male predominance, 2-to-1 and 3-to-1. Circling this just to show you that if you have an adult medulloblastoma, again, like think about, or older teenager, think about WNT. If you have infants, it's going to either be SHH or group 3. The histology for these, most of these are going to be classic. There's going to be some large cell anaplastic ones in group 3 and 4, but SHH is going to be the most diverse for histology. It can be classic. It can be this, what's called desmoplastic nodular or large cell anaplastic. Some of the key molecular changes or genetic changes for WNT is this mutation in CTNNB1. You can have multiple different types of mutations in SHH. One of the most important one is TP53. Group 3 can also have a MYC amplification. This is an oncogene. And then group 4 can be characterized by loss of chromosome 11. So not all, I would say not all group 4 have chromosome 11 loss, not all group 3 has MYC amplification. But the reason why these are highlighted in yellow is because when you find that within that subgroup, it actually changes its risk. And so you can see the survival again for WNT is very good. But SHH, group 3 and group 4, they all have a range actually. So you can see like SHH can be very poor to pretty good, and poor to good for group 3, and then also the same thing for group 4. So what's the deal? Like, you have these 4 subgroups, but then the outcome really is only different for WNT. And so the reason for this actually, if you actually look at medulloblastoma subgroups by risk, they actually can be categorized as different risks too. So WNT most always is pretty low risk. That doesn't change. SHH can actually have 2 kind of like large groupings with pretty good risk. So like between low to standard risk. So their survival is going to be probably high 80%. And these are only really seen in the infants who have this desmoplastic nodular pattern. We'll talk about this, but this is specifically categorized as this medulloblastoma with extensive nodularity, so MBEN. This has been recognized as a type of medulloblastoma that has pretty good outcome. But when you start seeing older children and even adolescents with SHH, or when they have metastasis, they have this large cell anaplastic histology, when you have TP53 mutation, and you have this MYCN amplification. These are all findings within SHH that makes it actually very high risk. So you can see that within SHH, there's actually 2 different groupings even within SHH. And you can find that too with group 3. So if you have a group 3 tumor that has no metastasis and no MYC amplification, then it's going to be standard risk. But once you see metastasis or that mutation, then it's going to be very high risk. And this is less than 50% survival. Group 4 actually has a very low risk group. When they lose the chromosome 11, this actually makes it a pretty good outcome, almost like a benign tumor. But then when they have metastasis, it falls down to high risk. So you can see that, there's actually, if you want to talk about risk, there's 1, 2, 3, 4, 5, 6, 7. You can actually divide medulloblastoma into potentially 7 groups. And so that's what this author did. They looked at the clinical differences between medulloblastoma groups. And you can see that, they divided it into 7 different groups. Some authors even want to divide medulloblastoma into 12 groups, right? So they look at WNT, different ages. I find this like kind of just a little too complex for me. I'm just a simple radiologist, right? So there's a lot of things going on here. And even like the survival is very similar between these WNT groups. And the only reason why they did this, I think, was because of, kind of a chromosome 6 issue that they found. But ultimately, clinically, they look very similar, right? So WNT typically has very good survival. Here within SHH, the only thing I would focus on here is this desmoplastic kind of infantile, this MBEN, medulloblastoma with an extensive nodularity. So that out of these 12, that's the one I would focus on. Okay, so let's talk about radiogenomics, right? Because we're radiologists, we want to see like what actually, how can we kind of subclassify these groups based on what we find. So the location, WNT, tends to be in the CP angle. Although I did show you this case that we had actually was midline, so it's not 100%. It's going to be in the CP angle. And I will say that the one paper that actually describes this, they have a small number of WNTs, and that's because it's rare. It's 10% of all medulloblastomas. So, but however, by literature, it is off midline, the CP angle. SHH, our experience is that it is kind of off midline as well, and tends to involve the cerebellar hemispheres. Group 3 and Group 4 are classic locations in the midline and the fourth ventricle. The margins tend to be ill-defined for SHH in Group 3. And contrast enhancement happens in all 3 of these groups except for Group 4. So that's the distinguishing difference between Group 3 and Group 4. So if you have a midline fourth ventricle tumor that enhances, it's Group 3. If you have one that does not enhance, most likely Group 4. And then finally, metastasis can occur with all of these. However, is more commonly seen in Group 3 and Group 4. So these are very specific things that you want to look for as you're dealing with a medulloblastoma. So here's the paper by Perot et al. So we can see these are the examples that they had for the WNT medulloblastoma in the CP angle. Here's the SHH. You can see that their examples involve the cerebellar hemispheres, and it's actually in and invasive in the hemisphere itself. Here's a pretty typical example of Group 3 tumors, which are classic midline fourth ventricular tumors that have intense enhancement. And then finally, we have these medulloblastomas, the Group 4 tumors that are midline, but not much enhancement at all. So I'm going to show you some cases where you can kind of see what the medulloblastoma with enhanced nodularity. So these have to be in infants. So here's one patient, which is a 1-year-old female. And here you can see this is a little bit more midline, so not as typical for SHH, but here you can see like big nodules, right? So big nodules, kind of grape-like clusters, enhancement, and obviously the ADC is dark, so telling you this is a high-grade neoplasm, high cellularity, sorry. Here's another case, which also is a MBEN. This is again, very nodular looking, kind of grape-like clusters. This one's in the vermis of the cerebellum and kind of even extends towards the midbrain. Here's another case, which is pretty classic for an SHH, medulloblastoma. It's in the cerebellar hemisphere. It also has somewhat of a nodular component. A 3-year-old male. And then finally, this case in a 2-year-old female, again, kind of a cerebellum vermis, kind of an invasive kind of tumor, but very kind of weird looking cerebriform, kind of nodular looking enhancement. So these are all under pathology. This was had the desmoplastic nodular histology. So in younger children, so this is 3 or less, this is the medulloblastoma with enhanced nodularity. And so this is the SHH pathway, and these kids have a good or low risk survival. So when you see this, definitely think about calling this in your report. Okay, so here's a kind of like a handy flow chart that I would use, I guess, when we're dealing with, when you think this is a medulloblastoma. Now remember, look at the tumor location, of course, whether it enhances, age is very important, and whether there's metastases. So if we start with location, we either have off midline or we have midline, right? So off midline is WNT or SHH. midline, the classic location is group 3 or 4. So if we look at the off midline tumors and then we look at age, if we have an older kid, a teenager or adult, then maybe we could suggest that this is a WNT tumor. If we have a child or infant, it's probably going to be SHH, right? But in a child, if they have METs, this is going to become a SHH very high risk. Even in the infant, if they have METs, this is probably going to be SHH very high risk. In the infant, however, again, like I showed in those previous cases, if you have this nodular grape-like appearance, then it's going to be MBEN, the enhanced nodularity, and it's going to have a lower risk. So now turning to the midline, the group 3 or 4, if it enhances, probably a group 3, but if it has metastasis, then you're going to have a group 3 very high risk. If there's no enhancement, group 4, if it has metastasis, it drops down to at least standard to high risk. All right, so that's medulloblastoma in a nutshell. So now we move on to another tumor. And here's two of the same type of histology. However, they also have very different outcomes. So here you can see on the first images here, we have T2. This one's a little bit bigger tumor. And you can see that it oozes kind of out of the lateral area here, the foramen of Luschka. And here this tumor, kind of heterogeneous with cysts, but it is kind of lower fourth ventricle near the obex, very midline. And then on sagittals, you can see that maybe it oozes down out of Magendie, so midline. On diffusion, the top row, this tumor, it doesn't really look that dark. And so maybe it's not that high grade. In this midline tumor here on the bottom row, we do see some areas that are a little bit brighter on B1000, maybe a little darker. And so there can be like maybe little nests of hypercellularity. So if I was reading this, I would maybe say that this could be anaplastic, grade 3. And then they both have some heterogeneous enhancement. So for those of you looking, and I guess what this is, with this kind of like toothpaste kind of oozing out of the fourth ventricle, this is an ependymoma, right? So both of these are ependymomas. However, their outcome is very different. The top one was in a younger child, 1 year, 3 months, and these are typically associated with the type A posterior fossa ependymomas, and these actually, unfortunately, have very poor outcome. The bottom row was in an older child, 11 years old, and so these are associated with the type B posterior fossa tumors, and these guys have a pretty good outcome. And so age is very important for ependymomas, as well as some radiogenomics, which I'll show later. So if we're looking at ependymomas kind of located throughout the CNS, we can see that the supratentorial lesions for ependymomas, there's basically two that we know of. There's the RELA gene fusion. This is the most common one. About 70% of supratentorial ependymomas are going to be RELA fusion. Only about 11% are going to be this YAP, YAP1 fusion. They can be either grade 2 or 3 for both of them, but that doesn't really matter because it's really whether it's RELA fusion or YAP1 fusion that's actually going to give you the differences in outcome. So the RELA fusion will be kind of all ages, but typically includes your older children, whereas the YAP1 fusion is going to be in younger children. Okay, so if you see a supratentorial ependymoma and you see mostly like kind of like a younger age, you may be thinking about YAP1, but it is not as common, unfortunately. And so we kind of talked about the infratentorial ependymomas as well, the type A and the type B. And again, the more common one is going to be the type A, which unfortunately is the poor outcome. And as we saw in the case before, it's the younger patients actually in the infratentorial space that are associated with poor outcome type A's. And also in more recent literature, and we'll see this gene later, but this is actually the protein. And so H3K27 is the gene, and the ME3, the 3 is the methylation. And so this is actually a methylation epigenetic modification. And the A types actually have decreased methylation compared to B types. And then finally, if we're looking at the spinal cord, we see that the spinal cord ependymomas typically are in adults. So not really a pediatric tumor, but just to show it to you for completeness. And so 40% of the spinal cord ependymomas can be associated with NF2, and then 48% are the classic myxopapillary ependymomas that we see at the distal end of the spinal cord in the conus and the cauda equina. And you can see it doesn't matter actually what grade they are, their outcomes are always pretty typically good. So again, for radiogenomics, we kind of went through this already with the two different types of posterior fossa ependymomas, but the A subtype is going to kind of like be more lateral, associated with oozing out of the foramen of Luschka. There can be more invasion of the brainstem or cerebellum here, and this is typically in younger patients. The B subtype, which has a better outcome, is more midline, kind of oozes out of Magendie, and typically in older patients. All right, so I just wanted to show you some cases of RELA fusion ependymomas. And so this is in a somewhat younger child, 23-month-old male. This has a pretty interesting appearance of this kind of nodule and cyst, but is more peripheral. So remember that supratentorial ependymomas can arise from the periventricular location because of ependymal rests that are adjacent to ventricles. And so you actually find them more here instead of in the ventricle, like you would in the fourth ventricle in the posterior fossa. And you can see this one actually has quite a bit of, this is a CVV map from DSC perfusion, and also quite a bit of decreased diffusion. This is B1000. Here's another RELA fusion ependymoma. This is a kind of an older child, but still it was RELA fusion, which unfortunately has a worse outcome. Very similar to the prior examination. We have kind of this nodule with a cyst, enhancement along the cyst wall within the nodule, and then the solid component has decreased diffusion and quite a bit of increased perfusion. Okay, so now we're going to move on to another set of pediatric brain tumors. So this one is again in the posterior fossa. And so here we can see that kind of heterogeneous, it's kind of off midline here, maybe centered in the middle cerebellar peduncle, enhances. There's these like pretty large peripheral cysts. And here we can see on the ADC map, it's pretty dark. So it's hypercellular, and we're thinking it's going to be a high-grade tumor, right? And on the perfusion, you know, it's pretty highly perfused. This is a younger patient at about 14 months. So the most common high-grade tumor in the posterior fossa, as you know, is going to be medulloblastoma. However, if we have this kind of off midline location, maybe you're thinking like WNT medulloblastoma or SHH or whatever. But with these like pretty big peripheral cysts in a younger age, I actually think about ATRT. Supposedly this kind of peripheral large cysts are more associated with ATRT than medulloblastoma. Usually you won't see big kind of peripheral cysts with medulloblastoma. And central cysts are more likely to be central necrosis, but here you can see like this is kind of a hallmark of this type of tumor. So ATRT already, you know, people knew that they had this loss of chromosome 22 and mutation in SMARCB1, and so this is actually, it can be seen in all types of ATRT. So it's a good kind of confirmation for our pathology friends when they see this mutation. However, even within the past 2 years, we've actually found subgroupings in ATRT too as well. So there's this TYR subgroup. Again, we see this SHH subgroup, and then the MYC oncogene subgroup. So here, this column that's not in a box is really all ATRT average. So these tend to be in younger patients. So when you see younger patients, think ATRT. However, we do see in the MYC subgroup that we can have adults, pretty rare, but if you have an adult with an ATRT, it's probably going to be the MYC subgroup. And the TYR tends to be the younger subgroup in the infants. The molecular changes, all of them have this kind of SMARCB1 mutation. However, in addition, the TYR subgroup has this tyrosinase mutation. SHH again involves the SHH pathway. And then the MYC has an elevated MYC oncogene. And this is a little bit different from the amplified MYC that we saw in medulloblastomas. It's just elevated and not like amplified in different copies. And then finally, for survival, they're actually all poor. So they haven't seen necessarily a different outcome in these three groups. However, with SCL1 mutations in the SHH subgroup potentially could have better outcomes. So I would say, you know, like just keep your eyes peeled in the literature to see if there's any updates in this data for ATRT to see if like the subgroups actually have different outcomes like medulloblastomas do. And also within the last 2 years, there's one paper that actually looked at radiogenomics for these ATRT subgroups. So the location again for these different subgroups are a little different. So if you have a posterior fossa location, most likely it's going to be the TYR. However, there also is supratentorial locations for this. The other two tend to like trend more to the supratentorial space. And then if you have this rare kind of spinal ATRT, it's going to be MYC for sure, because we haven't seen any MYC subgroup within the spine ATRT. Contrast enhancement is kind of plus minus for TYR, so there could be some non-enhancement here for ATRT, and then more strongly enhancing for the MYC subgroups. And edema also is more likely, the peritumoral edema is more likely for MYC, and then pretty uncommon for TYR. And then finally, like the hallmark finding, the peripheral cysts are more likely for TYR, but not as likely for MYC. All right, so I'll just show you some cases that we had for ATRT. So obviously, like we didn't, like this is within the last 2 years. So, you know, we haven't subtyped our ATRTs, our lab doesn't do that. So, but this one, you know, it's kind of an interesting tumor. You can see that, there's these smaller peripheral cysts, right, in this posterior fossa. And then there's actually multiple little nodules actually. So there's one here in the cerebellum, in the fourth ventricle, and also anterior to the brainstem. And you can see on B1000, it's pretty bright. So we know that this is a hypercellular high-grade tumor, quite a bit of increased perfusion. And so, I mean, you could think about some weird medulloblastoma, but we know that this is ATRT. And I would probably put it in the SHH or TYR group. It's a 3-year-old child, so somewhat young. This was an interesting ATRT that we had that was in the supratentorial space. So this is kind of like more cortical. Here you can see that there are a few little cysts, but it's definitely not the predominant feature. There's this kind of lobular looking enhancement and a very dark rim of ADC. So again, a high grade tumor. And here is a perfusion map from ASL, arterial spin labeling. And we can see that there's definitely increased perfusion here. And this is an older child. And so we know that supratentorial locations prefer the SHH or the MYC, but definitely like if it's an older child, it's probably going to end up being MYC. All right. So we're going to go to our last group of tumors, which is the glial tumors, the pediatric glial tumors. And so we'll split these between low-grade and high-grade tumors. So low-grade tumors, typically what we're dealing with are BRAF mutations. And there's two main ones, which is the BRAF KIAA 1549 fusion, or shortened to be BRAF fusion or BK fusion. And the other one is a point mutation at V600E within the BRAF genome. And so these are the most important mutations for low-grade glial tumors. For high-grade tumors, we get into the histone mutations. So remember, histones are those protein molecules that the DNA wraps themselves around. So this is an epigenetic phenomenon. The histone genome itself, H3K27M, can be mutated, but these can have like variant proteins. So it's like H3.3 or H3.1. We don't need to necessarily get into these, although I'll show a slide later, the differences between the two. But H3K27M mutations encompass both of these. Okay, so let's compare these two tumors. And here you can see on T2, this one involves the medial temporal lobe, as well as the midbrain, very heterogeneous, lots of cysts, causing hydrocephalus, obviously. This one's a little smaller, but similar location, mostly midbrain. Not a whole lot of medial temporal lobe here. We can see on post-contrast imaging that the tumor on the top kind of has I would say, a broad dural base too. So here's the tentorium, and here we can see that it kind of goes along the tentorial edge. So this enhancing nodule has essentially what we call a broad dural base. Here, this one, not really. It's kind of in the midbrain, kind of a solid, just kind of round enhancing nodule. And here's the ADC map. And you can see this one's kind of more ISO intense. This one's definitely has facilitated ADC or actually increased diffusion. So this is definitely going to be a low-grade tumor. This one may be a low-grade tumor. So these have different BRAF mutations and also suggest different types of tumors. So this one had a BRAF V600E point mutation, and this is more specific for pleomorphic xanthoastrocytoma or PXA, and the BRAF fusion is more specific for pilocytic astrocytoma. And so we can also tell this just by imaging alone. We can, when we kind of look at the dural margin, the PXA will typically have a broad dural base. That's one of the hallmarks of PXA. And so therefore the V600E point mutation is more likely with the PXA. So here's a kind of a table from Horbinsky et al. When we look at low-grade gliomas, when there's a BK fusion, this is actually pretty handy for our pathology friends because then they know this is not going to be a PXA and this is not going to be a high-grade glioma. So here, when you have a BK fusion, more than likely it's going to be a pilocytic astrocytoma or pilomyxoid astrocytoma, which essentially is just a cousin to the pilocytic astrocytoma, but not a PXA. It can be a ganglioglioma or even diffuse astrocytoma, but it's not going to be a high-grade glioma. So this is a pretty important mutation for our pathology friends. The V600E, again, is probably going to be low-grade and most likely a PXA, but there's a small percentage that can be high-grade glial tumors for the V600E. Also, not just for diagnosis, but the BRAF V600E inhibitor, there's actually drugs that are developed that kind of act against that. And so it's actually pretty important for our oncology friends when they're dealing with this type of tumor with this V600E mutation that they can actually use chemotherapy that actually targets this mutation. Okay, let's look at some, again, with glial tumors, let's look at some thalamic glial tumors here. So in the top row, here we have FLAIR images now between these two tumors. And here we can see this tumor kind of expanding the left thalamus for both of these. And it's kind of bright on T2. This one's obviously bigger and causing more hydrocephalus, but otherwise also bright on T2. On post-contrast, there's not much enhancement in this top tumor here. On the bottom, mostly non-enhancing, but there is a little bit of nodular enhancement in the middle. And then on the ADC maps, we can see that there's not really any decreased diffusion, mostly facilitated diffusion. Here, definitely mostly facilitated diffusion, although that nodule is a little darker, but probably not darker than the brain parenchyma. And then here are some cerebral blood volume maps from DSC perfusion. Again, like really no increased perfusion compared to the other side, almost decreased perfusion, even though the central nodules do have somewhat increased perfusion, but certainly not that much increase. So you would think that these tumors would be very similar, right? So these could be like low grade, you know, if it's in the thalamus, maybe like a diffuse astrocytoma or something. And the top one certainly was that. It was a grade 2 diffuse astrocytoma. This is a low grade glioma. Good outcome. This one ended up being a grade 4 high grade glioma with the H3K27M mutation. So even though radiographically these two are very similar, other than potentially this nodule enhancement, when you see this mutation and this histone mutation, H3K27M, it means it's a very poor outcome. Doesn't even matter what they see under the microscope or what you see radiographically. Having this mutation means poor outcome. Here's another case that we had in the thalamus. Again, the left thalamus was very popular at our institution. I don't know why. But here you can see, like on FLAIR, this is very well marginated T2 hyperintense mass in the thalamus causing hydrocephalus. There is a little bit of enhancement here, kind of almost like the centrally necrotic pattern. But when you look at the ADC, again, it's facilitated. So there's no way we'd be thinking about high-grade tumor, and perfusion's, pretty low actually. And so our my colleague, who read this is very good, thought this could be a pilocytic astrocytoma. And so pilocytic astrocytomas certainly can do this. They like to live around the third ventricle when it's under pathology. They even saw some kind of like cellular histopathology that suggested pilocytic astrocytoma. But we went ahead and asked them to do H3K27M mutation, and lo and behold, it was actually positive. And so for this tumor that looked like a pilocytic astrocytoma, even on pathology, they thought maybe it had a chance of being pilocytic astrocytoma. Doesn't matter. This mutation means poor outcome. And so unfortunately, this child died within 6 months of after this imaging. Here's the kind of the classic DIPG, or diffuse intrinsic pontine glioma. Here we can see on FLAIR imaging this kind of enlarged swollen pons kind of wrapping around the basilar artery. Most of it's not going to enhance, but there is some kind of like ring enhancement here in a portion of the tumor, which also shows a little bit of hemorrhage. And even on ADC here, we can see kind of this ring of a little bit lower ADC compared to the rest of the tumor, which shows kind of like a increased diffusion. So certainly, you know, if you look at most of the tumor, it looks like it's low grade, but we all know that DIPG is a high grade tumor. Most of these children unfortunately die, you know, in a year to 2 years. Here's another case of a pretty classic DIPG. Again, enlarging the pons, kind of circling around almost the basilar artery. Most of it's not enhancing. This one also has this kind of like little bit of ring enhancement in just a small portion of it, which shows a little bit of decreased ADC, but the rest of the tumor looks like has increased diffusion. So if you average this out, certainly it would seem like it would be increased diffusion, where you would see a low-grade tumor and not increased perfusion, but we do see a little bit of perfusion, again, in that ring. And so, again, this also was a DIPG. So even if you're radiographically suggesting that, you know, it could look low-grade, it's, you know, we all know that this is going to be a poor outcome tumor. And so it's been in my experience that when we see this kind of like this area of ring enhancement, which has a little bit of a lower ADC and potentially a little bit of perfusion, these are the ones that may have the H3K27 mutation and therefore poor outcome. You can have DIPGs that don't have that mutation, but it's rare. Here's another case of a glial tumor, a little bit off midline this time. It's shifted away from the pons a little bit into the cerebellar, middle cerebellar peduncle. Even has a little pedunculation here, and into the deep cerebellar white matter here on the left. We can see this expands kind of the dorsal pons as well as the medulla. Has this kind of like little bit of ring enhancement. Here's a B1000 image on diffusion. We can see a little bit of decreased diffusion here, as well as a little bit asymmetric increased perfusion. And so this was a little worrisome, even though pedunculated brainstem tumors could potentially be pilocytic astrocytomas. Some of these findings were a little worrisome. And this was also H3K27 mutated tumor that involved the cerebellum as well. All right, here's another glial tumor, again, spinal cords in the CNS. So this one caused expansion, T2 hyperintensity of the lower thoracic cord. We can see on post-contrast, maybe there's a little faint enhancement, not a lot. And here's a ADC map actually of the spinal cord. Looks about the same as the rest of the cord, so not high, not low. But on post-contrast, we can actually see this kind of thick enhancement here along the phylum. And then if we go back to the sagittal here on the upper part, we can see areas of probably like leptomeningeal enhancement along the cord. And this is confirmed on the axial images. Here we can see a little bit of leptomeningeal nodule on the cord. And even in the brain, we can see there's increased enhancement here in the leptomeninges and involving the optic nerves here. And so this is probably a primary tumor here of the cord with leptomeningeal metastases. Now this was kind of confusing at first in this child. When we looked at this, we thought about neurosarcoidosis too. But finally, we were actually able to get our neurosurgeons were actually able to get a biopsy, and this was confirmed to be an H3K27 mutated tumor. And so when we look at the kind of the 4 different areas that this type of tumor can involve, we see the thalamus, the pons, the cerebellum, and the spinal cord. This is now like classified together as diffuse midline glioma. So most of these 70 to 8% of them will have the H3K27M mutation, and therefore poor outcome. So a lot of times, most of the patients unfortunately die at least within 2 years. So here's a table kind of looking at high-grade gliomas in pediatrics. And we see that actually the histone mutations are actually half of them. Half of them have histone mutations. So if you're dealing with a high-grade glioma, half of them will have histone mutations and therefore poor outcome. Here we can kind of see the different variants between H3.3 and 3.1. And really you can just classify them together. The 3.1 variant tends to be a little bit more in the pons. The diffuse midline glioma, which can also involve the pons, is a 3.3. They're very similar in their overall survival, about 10 months, 3.3, and then 15 months, 3.1. I didn't really show this. I'm not sure that we actually have a case of this, but this G34RV histone mutation is typically a little bit older patients and involves the supratentorial space and more, not midline, but a little bit more peripheral, involving the hemispheres and actually near the cortex. So if you're not dealing with histone mutation, sometimes you have an IDH mutation. And so for those of you that are familiar with IDH mutations in adult glial tumors like glioblastoma or anaplastic astrocytomas or diffuse astrocytomas, this is the same thing, IDH mutations. There's also, again, the BRAF V600E point mutation, this PXA-like high-grade tumors, as well as some others, which include like infantile glioblastomas. So it's important to note that infantile or children glioblastomas don't have as poor outcome as adult glioblastomas. So these are not histone mutated, even though their outcome is not great, they still do a lot better than these histone mutation high-grade gliomas. Okay, so in summary, we can see that tumor genomics are very important, and that in most cases it causes very different outcomes in even the same histologic tumor. You know, remember the medulloblastoma for WE and also the infant SHH with the MBEN. You know, they have essentially benign outcomes, and also mutations also serve as gene-targeted chemotherapy as well. And so when we're dealing with radiogenomics, of course, look at where the tumor is, look at the age, whether there's metastases, and just remember that ADC, although it correlates really well with tumor grade, it doesn't always predict your outcome, right? So medulloblastomas that do really well, they have low ADC, they're high-grade tumors, but some of them have really benign outcomes. And so this is new information. Some of this, you know, especially ATRTs, like within the past 2 years, even medulloblastomas within the past 10 years. So we're not done learning. So there's going to be new literature out that may suggest better ways for us to correlate radiologically, also with different outcomes in some of these tumors and how to subclassify them. And so what are some future directions, especially for radiogenomics? Well, some of the papers with radiogenomics, and there's not a lot in PEDS tumors, just basically deal with conventional imaging. So they're T1, T2, post-contrast location, right? We do have more advanced MR imaging, biomarkers that can correlate with these genomics. So we can do perfusion imaging, we can do diffusion kurtosis, we can do MR spectroscopy. All of these things can be added to our growing knowledge of radiogenomics in correlating with different tumor classifications. And even the advanced biomarkers, these MR biomarkers can actually serve as independent biomarkers correlating with survival. So for example, if your cerebral blood volume is very high, it can serve independently as something with a poor outcome. So we may not even have to correlate with genomics. And finally, you know, when you're adding all of this data, right? So this is great for artificial intelligence, machine learning. So this could be another way of kind of predicting what, not just what the histopathology of these tumors are, but also what subclassification they are. Just wanted to show you a few cases as we're doing perfusion imaging at our shop. Here again is the posterior fossa ependymomas, this type A, you know, in the younger kid with the poor outcome, and type B in the older kid with a good outcome. Here's their perfusion imaging. You can see it's quite a striking difference. This is the cerebral blood volume for the poor outcome imaging. We can see it's really high. And then here's the one for the the good outcome imaging, you can see it's not so hot. So already we're starting to see some differences, and we're just waiting to collect enough cases, to make sure that these differences hold up. Here's a case of a pretty classic looking medulloblastoma, right? So fourth ventricle midline tumor with low ADC enhancing. So maybe it's a group 3. Here's some of the different perfusion imagings that we do. So we do dynamic contrast enhancement, DCE as well as DSE, and this can give us like very different parameters. And so these 4 perfusion maps are from DCE, and this one is from DSE. This is CVV. And we see that it's definitely increased here on CVV, and really only increased on this parameter that we call VE, which is a extracellular volume. Now compare that to this case that I showed earlier, which is a younger patient, SHH medulloblastoma, the MBEN with good outcome. Here's their perfusion maps. So now notice that the CVV is definitely decreased compared to the group 3 tumor that I just showed. There's relatively low VE. And then there's actually high K2 and KEP. So K2 is actually from DSC perfusion and is an indication of leakage. So we can see more leakage here, as well as this KEP, which is plasma volume. So how much of the contrast actually recirculates back into the plasma, so the blood vessels. And so that indicates more leaky vessels. And so this suggests that these have very, very different perfusion characteristics. All right. I'd like to end the talk with just a short quiz to see how well you're paying attention. Go ahead, and if you can open a web browser to kahoot.it. Sorry. Okay, here we go. Okay, so if you're on kahoot.it, basically you need to put in a pin, and it's going to generate this pin for you. So go ahead and type this number in, and then you'll be able to take the short quiz.
Hold on, Chang. Let me try to open Kahoot.
Maybe we won't have any players. All right, we've got one person. We've got a G. Thanks, G.
So we have about like 25 people on Zoom and about like 24 people on Facebook Live watching right now.
Okay, I guess we're gonna test the knowledge of one person, so that's fine.
Hey, hold on.
Start.
Start.
All right, which medulloblastoma subtype is most likely for this image? So this is a T1 post-contrast. See this classic midline tumor with some enhancement. So your answers are WNT, SHH, group 3, and group 4. All right. Group 3. That is the correct answer. Sorry, G. This is a classic kind of midline tumor, right? And so it's either group 3 or group 4, because off midline is going to be WNT or SHH. And then the way to distinguish between group 3 and group 4 is basically enhancement. And so because this thing enhances, it's probably going to be more of a group 3 tumor. All right, let's go on to the next question. So what histology and subtype is this tumor in a 1-year-old patient? This is a young patient. This is a tumor that kind of oozes out of the kind of laterally, foramen of Luschka. Is this going to be a WNT, medulloblastoma, SHH, PFA ependymoma, or PFB? All right, so we have PFA selected here. This is the right answer. So remember that tumors that ooze out of the fourth ventricle are more likely to be ependymomas. And if they're more lateral than in a younger patient, for sure, then it's probably going to be PFA, which unfortunately has a poor outcome compared to PFB, which is more midline and also in older children. All right, good job, G. Next question. So which mutation is highly associated with low-grade tumors? Is it going to be the SMARCB1? Is it going to be the BRAF fusion, H3K27M, or the MYC amplification? All right. So somebody chose BRAF fusion, which is the correct answer. So SMARCB1 is going to be for ATRT, right? So that's a high-grade, kind of poor outcome tumor. BRAF fusion is most likely going to be seen in pilocytic astrocytoma, so low-grade tumors. So good job, whoever answered that. H3K27M, again, remember histone mutation associated with like diffuse midline gliomas, very poor outcome, probably patient death within 2 years. And then the MYC amplification can be seen with medulloblastomas in group 3s and usually associated with very high risk, so usually poor outcome. So BRAF fusion is the correct answer here. All right, TS, gaining ground. All right, diffuse midline gliomas occur in what anatomic location? The thalamus, the spinal cord, the brainstem, or all of the above? All right, so we have some split answers. Definitely can occur in the spinal cord, but definitely can occur in thalamus and brainstem. So, I did show cases for diffuse midline gliomas in all 3 of these locations, especially the DIPG pons, as well as the cerebellum. And so all of the above is correct. So usually when somebody gives you all of the above, it might be the correct answer. I don't know. All right. G got 3rd place. G also got 2nd place. And number 1, TS. Look at that. Congratulations, TS. I wonder who that is. Great. Well, that does it for me. I guess I can take questions if anybody has some questions.
Thank you so much, Dr. Ho, for giving like these very informative lectures. There are too many details, and I mean like that we need to remember. So I have a couple questions for you. You mentioned about like the technique, like the standard technique, like pre and post contrast, which we have a DWI, and you also mentioned about like the perfusion technique and also MR spectroscopy. So for the perfusion technique, which technique do you think is the best one to do, like a DCE, DSC, or ASL perfusion, or what do you recommend? Because maybe like some places cannot do like a 4 technique as we do at Riley.
Sure. Yeah, so we do a lot. We kind of throw the kitchen sink at it, as you know. So I would say the most mature techniques are going to be the contrasted techniques. I know there's at least a few years ago, there was a lot of like, oh, should we give contrast to our patients? And I think that, we shouldn't throw, in American idiom is called throwing the baby out with the bathwater, right? So you shouldn't just throw all that out, especially since these patients are going to be having a lot of contrast. I mean, these patients do have tumors. You're probably not going to evaluate them without contrast anyways. And so I would say the contrasted perfusion techniques are probably the most robust. They're less susceptible to post-processing and differences in those types of things. So I would say DSC for sure, and then DC as well. But DSC probably has the most bang for the buck, as in just looking at it, right? So if you're able to have your text like post-process it and generate a cerebral blood volume map, you can clearly tell just on the color map whether it's increased or decreased. And it seems like, at least from early, research that we're doing, If it has high perfusion, it probably means that it has a poor outcome.
So you would recommend the DSC?
Yes.
As like the initial study when the patient come and we see like a tumor,
Right.
and we do like some grading stuff. So DSC is like a
yes.
And how about like a spectroscopy? Do you think it's like a value added, or is probably not?
Yeah, we don't do a lot of spectroscopy for our tumor patients because there's really not, when you're looking at just your typical profiles of your lactate, your NAA, and your choline, and maybe myoinositol, a lot of times the pilocytic astrocytomas actually look similar to our high-grade tumors. That is that they will have some lactate, right? They're gonna like kind of grow out of their blood supply. All tumors can do that. And then obviously when you have tumors, they tend to replicate faster than normal tissue. And so their choline is gonna increase anyways. You have to actually, you can't just like eyeball the spectra to tell any of them apart. You can basically say, yeah, this looks like a tumor. That's really all you can say. I think the spectroscopy is kind of still in the research realm for tumors. There's been some papers that show that you can kind of separate based on how high the choline peak is, like how aggressive it is. So you could do that, but that really requires you to have really good post-processing software that can actually give you real numbers instead of just looking at the spectra.
So maybe like a spectroscopy is not that useful.
Yeah, I don't think clinically is as useful. I think you can certainly in the research realm maybe pick up even more metabolites, that would be more specific to a tumor subtype. But again, that's more research than clinical.
Yeah. So which means like we rely on like the conventional technique and also perfusion. So which means on the DWI and ADC it's going to give us a lot of information to tell about high grade or low grade tumor.
Right.
Do you normally do like the measurement on the ADC value of the tumor compared to the like a normal white matter or gray matter, and what is the ratio if you do the measurement, and what is the ratio to suggest you this is like a high grade tumor or low grade tumor?
Oh, okay. So you're looking at basically if there's a quantitative value like as a threshold for what's high grade versus low grade. Yeah. So
yes, maybe high or maybe dark or not dark.
Right. So so like we were talking about, like even within medulloblastoma, if you have low ADC, it doesn't really help you with the subclassification, right? So group like a really good outcome WNT is going to have also low ADC versus a really bad outcome group 3 or whatever. So that quantification really isn't going to help there. When you're just dealing with like, are you putting it in a high grade or low grade category? That certainly helps. But again, there's not really any published necessarily thresholds. There is the older paper where they actually looked at like the numbers of ADC, and then they saw like, these generally tend to be the higher ADC values tend to be the low grade tumors, and the lower ADC values, the high grade tumors. And so that holds true. And so for clinically, like, we kind of just eyeball it, right? So we look at it, compare it to normal brain. If it's darker than normal brain, then it's certainly high grade. If it's like lower than normal brain, then it's low grade. Essentially, that's how we do it clinically.
So do you have any take-home point for the radiologist who reading the study? And I cannot remember like every detail that you're talking about genes.
Sure.
I just remember some specific detail, but I cannot remember all. And what information that you think is really useful to put in our report, or like which tumor and a specific genes?
Yeah. So I would focus specifically on the medulloblastomas and also the H3K27M mutations. Those are some of the more known pediatric genetic mutations or epigenetic mutations. So when you encounter a pediatric tumor that you think is going to be medulloblastoma, you don't have to memorize these things. You can just pull up like that chart, right? So you can have a chart with the four subtypes in kind of a handy like cheat sheet. Like, oh, is it off midline or is it midline? And then you can like kind of suggest that it's going to be one of these 4 subgroups. And especially if you have, and like I said, for the SHH medulloblastoma, in an infant with the nodular appearance, you should definitely suggest the NBEN, right? Because that could have a really good outcome compared to the other medulloblastomas. Versus if you have like a midline tumor, a group 3 or group 4, and you have metastasis, then that puts it in a very high risk, category. And so right then and there, I mean, you can already suggest that, you know what's going to happen, unfortunately, with, potentially what's going to happen with this tumor. And then for, I would say, the H3K27 mutations, anytime you're dealing with some kind of T2 bright tumor that's in the midline, always suggest it, right? Like encourage your neurosurgeons to get a biopsy if they can safely do so, because if you do find that mutation, unfortunately, there's no good treatment for it currently, but at least you can counsel the patient, and also give the family expectation of what's going to happen.
So I mean, like most of the brain tumor, the neurosurgeon need to get like a tissue or biopsy.
Yes, that's right.
Why we need to put that like a genetic things in our report? Because they are going to get it for sure after from the pathology.
Yeah, so especially with the midline, can be very risky. If you especially like for those thalamic tumors that may have this kind of slight nodule enhancement that you're like really suspecting, it could be H3K27M. If you don't suggest it, you don't push them, they will say, no, it's dangerous, we should just wait. And then the patient will be like, yeah, I mean, it could be a low-grade tumor. You might do okay. You'll live 5 years, but in actuality, if it's H3K27M, they probably won't live 2 years. And so I think that's a very key piece is to, if you suspect it, then you should get your surgeons to try to biopsy a piece if it can be safely done.
And how about a medulloblastoma?
Yeah, so medulloblastoma, a lot of times, like they're going to try to resect it as much as possible, right? So, I mean, it's in the posterior fossa. Neurosurgeons like to take it out as much as they can. But there, like as we saw, that there are some tumors that they may not be able to go after easily. And so if there is a kind of like an off midline tumor, that's kind of like pushing on the brainstem, neurosurgeons, like usually when you get a full resection, it has a better result, right? However, if there's ones that are like a little bit onto the brainstem, if you think it's going to be WLB, maybe they can not be so aggressive and actually cause severe harm to the patient.
Yeah, so I remember every time when you see a posterior fossa tumor in children, and you think it looks like medulloblastoma, but it happened in very young patient, we need to put the ATRT in our differential diagnosis, right? And during your talk, you mentioned about medulloblastoma has a Sonic Hedgehog subtype, which is in the parenchyma and has a nodularity appearance. And for the ATRT, also have the Sonic Hedgehog subtype. Is it like the same pathology or?
No, sometimes like you have, so the Sonic Hedgehog pathway, can be different for for each type of tumor. So like, we were talking about like, one of the things that also was like MYC, amplification or whatever, occur in medulloblastoma and ATRT. It can mean different things, for different tumors. And so, I would, even though it's SHH, like I would say like, yeah, that still means different things because it's medulloblastoma and ATRT. Because remember, like, the infant SHH, they actually do have like really good outcomes. Whereas like, as far as we know, ATRT, SHH, they have poor outcomes.
But it's like it's restricted diffusion, right?
Yeah, they're both decreased diffusion, right? So it's like, doesn't really mean anything, like other than it's high grade. You can say, okay, it's medullo or ATRT, but it's not going to actually predict your outcome.
That's good. Let me check. Do we have any comments from this? So they are stunning with all information that you gave on the lectures.
It's a lot, I know.
It's a lot. And I mean, I think we need time to digest this thing and memorize and remember on the specific genes. But I like your take-home point about Medulloblastoma is one of the most important diagnoses in the posterior fossa that we can tell the subgroup or radiogenomics, and also like a H3K27M mutation, which is like one of my favorite gene mutation. It's just like a one gene on the midline. Okay, so thank you so much, Dr. Ho, for giving us all information. And if you have like anything to tell the technologist or radiologist or like a clinician about the brain tumor, please do. Yeah, have any like a take-home point for them?
Oh, okay, sure. Yeah. So, particularly for technologists, like if you have radiologists asking for like these, perfusion images, now you kind of know why. I mean, they do take like, an extra 5 to 10 minutes to do. And then maybe some post-processing too as well. So again, I was trying to show like how our advanced imaging can really be used to correlate with some of the genetic differences. And so it's very important, if we're doing perfusion to do it like, to make sure to do it. Yeah.
Thank you so much. ขอบคุณค่ะ Thank you.
Yeah. Thank you. It's my pleasure to give this talk. So.
Yeah. I'm gonna talk in Thai. ก็ขอบคุณทุกท่านมากนะคะที่ติดตามชมคือเนื้อหาคงเยอะมากอะค่ะแล้วก็เป็นรายละเอียดที่ต้องใช้เวลาในการย่อยแล้วก็อาจจะต้องมาดูซ้ำอีกทีนึงเพราะในขณะที่ตัวเองเนี่ยก็ทำงานในเรื่องนี้มาเยอะพอสมควรเหมือนกันแล้วก็ทำงานกับดร.โฮมาตลอดเนี่ยบางครั้งก็ยังต้องขอคำแนะนำค่ะว่าจากอันนี้จะเห็นอะไรยังไงนะคะก็หลังจากจบเลคเชอร์นี้แล้วนะคะก็จะมีใบประเมินแบบสอบถามนะคะส่งให้นะคะรบกวนทำแบบสอบถามแล้วก็ตอบให้เสร็จภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์ตอนเช้าเนี่ยจะได้รับใบเซอร์ติฟิเคตนะคะแล้วก็ครั้งนี้จบแล้วนะคะของโมดูล 5นะคะของ Pediatric Neuroradiology นะคะอาทิตย์หน้าจะเป็นโมดูล 6นะคะในเรื่องของ Radiation Safety แล้วก็ Pediatric Radiology นะคะซึ่งจะเริ่มลงทะเบียนใหม่นะคะเริ่มได้วันนี้หลังเที่ยงนะคะในการลงทะเบียนใหม่ของโมดูลครั้งต่อไปนะคะแล้วก็ยังไงขอบคุณทุกท่านที่ติดตามมากๆค่ะตอนนี้เรามีช่องทางใหม่ในการติดตามนะคะคือช่อง YouTube Channel Imaging Academic Outreach Center นะคะถ้าสมมุติว่า Facebook มีปัญหาเนี่ยสามารถดูได้ทาง YouTube ได้นะคะขอบคุณทุกท่านที่ติดตามค่ะขอบพระคุณมากๆค่ะสวัสดีค่ะบ๊ายบาย Thank you so much Cheng Have a good night
Thank you. Bye-bye.